Good evening, everyone. Shall we start? Good evening, everyone. Is audio video clear? Okay, let's start then. Let's first do the MCQ of yesterday. Actually, the HSG and the hysteroscopy MCQs are not made, they are still pending. Rest all have been made. Okay, take the first MCQ, please. Okay, two slides were left yesterday. Two slides were left yesterday. Yeah, two slides were left yesterday. Let's see what are the slides. Yeah, two slides were left yesterday. Most common with Mullerian anomalies, as due to Mullerian anomalies, Mullerian or anomalies, they originate from Mullerian duct. It originates from mesonephros. Okay, Mullerian duct, it originates from mesonephros. So the and the renal ductule system also originate from the Mullerian duct. Okay, renal ducts also originate from the Mullerian duct, and the Mullerian, sorry, sorry. Once again, see, both the renal duct system and the Mullerian duct, they both originate from mesonephros. So both of them originate from mesonephros. Okay. So in a patient of Mullerian anomalies, it is but obvious that the patient has renal anomalies too. Okay. It is but obvious that in the patient of Mullerian anomalies, there is renal anomalies too are present. Renal duct anomalies too are present. So if a patient comes to you with Mullerian anomaly, you must rule out the renal anomalies, and that will be on the ipsilateral side. Ipsilateral side, that will be only on the one side, ipsilateral side. Okay, what is the investigation? Same side, because same side Mullerian duct and same side renal ductule system, they gives rise to the problem. Okay. What is the investigation of choice? What is the investigation of choice in Mullerian anomalies? The investigation of choice is 3D ultrasound. Okay, it is not plain ultrasound, please mind it. It is 3D ultrasound. Okay, This is not for the renal anomalies, beta. This is for the Mullerian anomalies. This has not been asked, but it can be asked. For Mullerian anomalies, the investigation of choice is 3D ultrasound, and the best investigation is MRI. This has been asked. This was a PYQ. Okay. And if they ask you best procedure, as they usually ask, beta, as they are usually asking, so the best procedure is to diagnose laparoscopy and hysteroscopy. Laparoscopy and hysteroscopy. Now see, what are the problems the patients they suffer if they have Mullerian anomaly? Okay, these patients, they can have, it is not necessary they will have, they can have recurrent pregnancy loss in the second trimester. Okay, they can have recurrent pregnancy loss in the second trimester. Okay, then there can be endometriosis. Okay, there can be endometriosis. More are these anomalies, more are the chances of backflow. Okay, more are these anomalies, more are the chances of backflow of the blood. Consequently, more are the chances of endometriosis. More are the chances of ectopic. Why it is so? Because Mullerian anomalies, they are related with fallopian tube anomalies also. So more are the chances of ectopic pregnancy. Because in the Mullerian anomalies, the uterus size is usually small. So they are associated with preterm labor. Okay, they are associated with preterm labor. So you should remember that Mullerian anomalies are related with the ipsilateral renal anomalies. Investigation of choice in Mullerian anomalies is 3D ultrasound. The best diagnosis is done by MRI. The best procedure is laparoscopy and hysteroscopy to diagnose the Mullerian anomalies. To diagnose the Mullerian anomalies. Why it is best? Because simultaneously we can operate also. Okay. Answer this question. Answer this important question. Without questions, the practice is incomplete. Diagnosis of biseptate uterus is by. Answer this question. Be fast. There is no lag. Yes, answer is hysteroscopy. ठीक है? No, Dr. Isra, the answer is hysteroscopy. Why the answer is hysteroscopy? Because what is happening here? What is happening here? There is problem in the uh, there is problem in the uh, endometrial cavity. So diagnosis is by hysteroscopy. It is not by HSG, because HSG is the investigation of choice. Whenever you are not written in the question investigation of choice or best diagnosis, you have always to choose the best diagnosis. Is it clear? Is it clear? The investigation of choice and best diagnosis is not written. You have to choose the best diagnosis. Okay? Okay. Now, what is the diagnosis here? What is the diagnosis here? This is again a PYQ. What is the diagnosis here? Septate uterus, because the angle between the cavities is less than 90 degree, more precisely less than 60 to 75 degree. What is its treatment? Very good. What is its treatment? What is its treatment? What is the treatment? Septostomy, septal resection, and that is done hysteroscopically. Hysteroscopically, very good. How this patient presents as? How this patient presents as? With what is the most common complaint? What is the most common complaint? No, here you are wrong. This patient does not present as infertility. This patient presents as recurrent pregnancy loss. Okay? Recurrent pregnancy loss if there is any presentation. Seen in MRKH. Seen in MRKH, bacha? Vaginal aplasia. Yes, it is right. It is vaginal aplasia. Ovarian agenesis is not seen. Very good. Ovarian agenesis is not seen, Dr. Sabri. Ovarian agenesis. Ovaries are perfectly normal. Ovaries are normal. Biconvate uterus is not seen. Okay, biconvate uterus is not seen and separate uterus is also not seen. This is seen in Mullerian anomalies. Okay, so they will always twist the question and give you best and worst OBS outcome in which Mullerian anomalies. These are the most expected question. Best and worst OBS outcome in which Mullerian anomalies? Yes. Best outcome is in very good, septate uterus. Best outcome is in septate uterus because septa can be, and worst is in worst outcome is in unicornuate. Okay, best outcome is in septate uterus. Okay, and worst outcome is in unicornuate. I'm sorry, actually I was seeing the message. The best outcome is not in septate uterus. Can you tell me best outcome? Best outcome means does not need treatment. Where is the best outcome? Can anybody tell me? The Mullerian, out of Mullerian anomalies, when is the best outcome? In the uterine didelphus. Usually no treatment is required. Uterine didelphus. No treatment is required. Okay. Which anomaly is there with complete failure of fusion? Complete failure of fusion. Which anomaly is there? Yes. Come on. And with incomplete failure of fusion? Write down the anomalies. Didelphus is the Very good. Didelphus. No, beta. Dr. Monica. No, no. Didelphus is with the complete failure of fusion. Two ovarian tube, two fallopian tube, two uterus, two cervix. Okay, two vaginas. Complete failure. And which is with bicornuate is associated with? Bicornuate is associated with? Yes. Incomplete failure. Incomplete fusion. Okay. Which is the most common Mullerian anomaly? Come on, everybody. Which is the most common Mullerian anomaly? No, didelphus patient usually doesn't present with any complaint. Incidentally, we see it during the best prognosis is arcuate, but usually we don't take arcuate as any problem. Best diagnosis is Dr. Sabri, it is arcuate. You are right. Okay, but usually we don't count arcuate as any problem, so that's why I mentioned there. Okay, so what is the most common Mullerian anomaly? What is the most common Mullerian anomaly? It is arcuate. If arcuate is not in option, then septate. Okay, so most common is arcuate. If arcuate is not in option, then septate. Is it okay? What is arcuate? What is arcuate? Slight curved fundus. Arcuate is slight curved fundus. Is it okay? Yes. Heart-shaped uterus. Slight curved fundus, it usually causes no problem and it is the most common anomaly. When to treat Mullerian anomalies? Yes, anybody? When to treat Mullerian anomalies? When to treat Mullerian anomalies? Uterine didelphus and arcuate, beta. Uterine didelphus. Dr. Isra is asking which anomaly is associated with less chance for recurrent abortion. So the answer is uterine. In first is arcuate, and then if arcuate is not in option, then it is uterine anomalies. Uterine didelphus. Yes. So answer to this is if symptomatic. Answer to this question is if symptomatic. Later. If symptomatic. It is what this is telling. This question is telling that usually Mullerian anomalies not present with any problem. Okay, usually Mullerian anomalies will not present with any problem and they are seen coincidentally. If symptomatic or it causes, what is the symptoms? Recurrent pregnancy losses. What is a symptom which requires surgery? Recurrent pregnancy losses. Now the question to your answer to your question, beta, which Dr. Isra has asked a question, which anomaly is associated with less chance of RPL. So what is the answer? What is the answer? Again, it is with the best odds outcome. Okay. So the answer is yes. So the answer is arcuate followed by uterine diadelphus. Okay. Uterine diadelphus. Very good. Okay. Dr. Monica, are you there? Dr. Monica, if you are there, then we will go with questions. If you are not there, then we will go with theory part. Are you there, Dr. Monica? I think she's not there. Let's start with theory. Let's start with amenorrhea. Yesterday we studied that ovaries originate from, come on everybody, ovaries originate from where do the ovaries originate? Yes. Where do the ovaries originate? The female genital tract originates from? Yes. Very good. So ovaries originate from the genital ridge. Female genital tract originates from Mullerian duct. Very good. Okay. Now here I would tell you that, okay, you are there. Dr. Monica, do you would like to do the theory or just answer? Okay. You would like to do theory. Okay. Ovaries originate from genital ridge and the female genital tract originate from Mullerian duct. What are the Mullerian duct derivatives? Be fast. Fallopian tube, uterus, cervix. Number 4 is fallopian tube, uterus, cervix. Then what else? Upper vagina. Is it okay? These are the Mullerian duct derivatives. Okay. Now these are the two structures, genital tubercle and genital swelling. They are present at 6 weeks in both male and female. Okay. If this genital tubercle, they get the presence of androgen. If in the body androgens are there and this genital tubercle, on the genital tubercle the androgen X, then what will be there? What will be formed? Penis is formed. And if there is no androgens, then this genital tubercle will form clitoris. Okay. So basically what we are studying? We are studying external genitalia. Is it okay? Genital swellings. If on the genital swellings the androgen X, If on the genital swelling the androgen X, what is formed? Scrotum is formed. Okay, scrotum is formed, beta. Scrotum is formed. And if the androgens are absent, then labia majora is formed. Then labia majora is formed. So where are the androgens? Androgens are present are produced by the testes. Androgens are produced by the testes. So if the genotype will be XY, then testes will be there and androgen will be there. Then male genitalia will be formed. This is somewhat normal, right? Now, if due to any problem there is no androgen, then what will happen? If due to any problem there is no androgen, then in this male there will be formed female genitalia. Can you tell me the problems in males where there will be no genitalia, female genitalia? Can you tell me? एंड्रोजन इन सेंसिटिविटी सिंड्रोम ओम, ठीक है. एंड्रोजन इन सेंसिटिविटी सिंड्रोम. What happens in androgen insensitivity syndrome? In androgen insensitivity syndrome, the androgens are present but they are not acting. Okay, androgens are present but they are not acting. Because they are not acting, so they no formation of male genitalia, only formation of female genitalia. Are the pubic hair present? Answer, ask the no, Dr. Isra, it is not clean filter. In clean filter, some androgens are, in clean filter androgens are not there, but some androgens in the intrauterine life, androgens are present. In the clean filter, in the intrauterine life, androgens are present. Okay, is it clear, Dr. Isra? Okay, now tell me whether pubic hairs are present or not. Whether pubic hairs are present or not. They are absent because pubic hairs are due to the presence of androgens. Androgens are present in androgen insensitivity syndrome, but they are not acting. Right? So the hairs will not be formed. Right? So, is the breast present or not in the androgen insensitivity syndrome? Androgen insensitivity syndrome, the breast is present or not? It is present because these androgen, or you can say the testosterone, they are of the male amount. In the males, there is very high testosterone, around 200. This testosterone is not acting anywhere, but it gets converted into estrogen, and this estrogen then forms the breast. So what are the peculiarities? What are the peculiarities of androgen insensitivity syndrome? Yes, what are the peculiarities of androgen insensitivity syndrome? Yes, XY genotype, testes. Number 3. Yes, number 3. Yes, number 3. Testes are present. Female external genitalia. Female external genitalia Number 4, female external genitalia. Number 4, no pubic hairs. And number 5, breast present. So these are the 5 peculiarities of androgen insensitivity syndrome, right? If you will remember these 5 points, you will never do any question of androgen insensitivity syndrome wrong. Okay. Now let us see female. In the case of female, yes, in the case of the female, if there is no androgens, so female external genitalia is formed by the genital tubercle and genital swellings. Okay, because there is no androgen in the females. Now if any problem occurs to female and there is excess of androgens, then in that female, or you can say in the XX genotype, there will be formation of male genitalia. Okay, there will be formation of male genitalia. What is the source of androgens? What is the source of androgens? The source of the androgens is, number 1, the source of the androgens is adrenal cortex. And number 2, ovaries. Is it okay? Is it okay? Now, what happens? What happens? In the adrenal cortex releases adrenal corticotropic releasing hormone. Hypothalamus releases adrenocorticotropic releasing hormone. Right? No, beta, it is fetal. This is fetal ovaries. Okay, adrenal corticotropic releasing hormone. Then they releases adrenocorticotropic from the hypothalamus. Then it releases is adrenocorticotropic hormone. Then this ACTH, what does it do? It changes the cholesterol into cortisone, aldosterone and androgens. Okay, this changes into cholesterol, aldosterone and androgens. How it is changed? This is the biochemistry. This chart is very important. It comes in skin, it comes in surgery, it comes in gynae, it comes in pedia. Okay, how it is changed? This is the biochemical pathway. The cholesterol is changed into pregnenolone. If you are the one who does not remember the pregnenolone name, Nane is Madhuri Dixit's husband. So, Nane has taken the loan for the pregnancy. Pregnenolone. Okay. Now, this pregnenolone is converted into 17-hydroxyprogesterone. Okay, it is converted into 17-hydroxyprogesterone and the further progesterone, and then at the last androgens. Okay, now this 17-hydroxyprogesterone is converted into aldosterone. This is converted into aldosterone. The progesterone is converted into cortisone, and the progesterone is also converted into androgens. For the 17-hydroxyprogesterone to change into aldosterone and progesterone to change, what are the enzymes working here? 17-hydroxylase and 21-hydroxylase and 11-hydroxylase. These are the enzymes that are working, 21-hydroxylase and 11-hydroxylase. So, if these enzymes they get deficient, then there will not be production of, yes, write down in the chat box, please. There will not be the production of aldosterone and cortisol. If there is deficiency of 21-hydroxylase enzyme, then there will be no production of cortisone and aldosterone. So, there will be no negative feedback, because what happens in our body only in this formation of cholesterol, changing of the cholesterol into cortisone, aldosterone and androgen occurs only 2 times, one in the morning and one in the evening. Okay, and the negative feedback is given by cortisone and aldosterone. Now when there is 21 hydroxylase deficiency, so there is no formation of aldosterone and cortisone. As a result, Jai Shri Krishna Soni ji, ठीक है, so there is no negative feedback. Okay, so there is no negative feedback. Is it okay? So there is no negative feedback. Okay, so this pathway keeps on running whole day. In a normal human being, this pathway keeps on running only 2 times a day, one in the morning and one in the evening. But when there is no formation of cortisone, aldosterone and androgens, this pathway keep on running the whole day, and it leads to yes, hyperplasia. This was there in the adrenal, and this lead to adrenal hyperplasia. Okay, this leads to adrenal hyperplasia. So this whole pathway increases, because this is running the whole day. There is no negative feedback. Aldosterone and cortisone are absent, so there is no negative feedback. There is no one to stop the pathway. Okay, so this cholesterol increases, pregnenolone increases, 17-hydroxyprogesterone increases, progesterone increases, and androgen increases. If androgen will increase, then what will happen? Now tell me, if androgen will increase, then what will happen? If androgen will increase, then what will happen? Yes? If androgen will increase, then in a female with XX genotype, there will be formation of male genitalia. Okay, there will be formation of male genitalia, right? In a female, there will be formation of male genitalia. Do you remember we discussed it here? That if the androgens will be present and in the congenital period, then there will be formation of male genitalia, right? So this you have to remember. Okay, very good, Dr. Sabri, very good. Okay, so let us subscribe it. In a short, when there is 21 hydroxylase deficiency, whenever there is 21 hydroxylase deficiency, there is no formation of aldosterone and cortisone, right? There is no formation of aldosterone and cortisone. Due to that, there is loss of negative feedback to the ACTH. Okay, and due to this, the adrenal cortex pathway keeps on running day and night. There is adrenal hyperplasia. Okay, there is adrenal hyperplasia, and due to that adrenal hyperplasia and the pathway is running day and night, there is excess androgens, and that leads to the formation of ambiguous genitalia, or you can say the male genitalia in the female. Beta, in the male what will be there? precocious puberty. Okay? In the male, there will be precocious puberty. Okay? Is it okay? So, what is the most common reason for ambiguous genitalia in male? Answer this question again. They are very important. What is the most common reason of ambiguous genitalia in the male? Yes, what is the most common reason of ambiguous genitalia in XY genotype? Answer it. Okay, now a short lesson about, yes, very good. Now a short discussion about intersex. Okay, what is intersex? The human being in which the both male and female features are present, that is known as intersex. What is intersex? Please answer. The human being in which the both male and female features are present, they are known as intersex. What is true intersex? In which both the gonads are present. What is true hermaphrodite? In which gonads are both ovaries and testes. Okay. And what is pseudo hermaphrodite? What is pseudo hermaphrodite? Pseudo hermaphrodite means that gonad is of the one type, one gonad, but external genitalia is opposite of that of gonad. Okay. Pseudo hermaphrodite means that external genitalia is opposite as that of gonad. Is it okay? Is it okay? For example, if ovaries are present, then external genitalia is of the male. And if testes are present, then external genitalia is that of the female. Okay. Now, to which pseudo hermaphrodite we will say that it is female pseudo hermaphrodite or male pseudo hermaphrodite? It depends on the gonads or you can say karyotype. Okay. What is Dr. Isra is asking to tell again? Okay. Beta, what is pseudo hermaphrodite? Pseudo hermaphrodite means gonad was of one type. Either the gonad was testes or ovaries. Gonad was of one type. Either the gonad was testes or ovaries. Okay, one type. Okay, yeah, very good, Dr. Sabri. Either the gonad was testes or the ovaries. Okay, either the gonads were testes or ovary. Only one type. Two type of gonadal tissue is not present. Okay, is it okay? But the external genitalia is opposite to gonad. But the external genitalia is opposite to gonad. If the gonad is testes, then the external genitalia is that of the female. Okay, that of the female. Is it okay? Okay. Now, to which what we will take? We will say a female. We will say that human being as female if the external genitalia is female or if the gonads are of the female. Tell me. We will say a female if external genitalia is of female, or if the gonad is of the female. Tell me, to which we will give priority. Dr. Sabri, tell me. Now we will see a female if ovaries are present or if external genitalia is female. Tell me. We will say a female if ovaries are present. Okay, we as a doctor don't care what is the external genitalia. We as a doctor knows कि the presence of external genitalia depends on androgen. Okay, so we are not dependent on the androgens or the external genitalia. Okay, we will say a female if the karyotype is XX or the now there is a female. I think you are not understanding the question. There is a human being, okay, whose is ovaries, gonads are ovaries, or genotype is XX, but its external genitalia is that of the male. Now you will say it female or male. Now you will say it female or male. Yes, Dr. Sabri, you are right. Now you will say this female as female or male. My question is this. Yes, you will say it as female. Why? Because you should know in mind that karyotype dominates. Okay? Because karyotype dominates. Okay, what is the karyotype? We will not rely on the genotype. Okay? Is it okay? So now you tell me, what is the most common cause of ambiguous genitalia in male? Yeah, there is long lag. What is the most common ambiguous genitalia in males? Yes, what is the most common ambiguous genitalia, cause of ambiguous genitalia in males? Yes, it is in the XY genotype. It is androgen insensitivity. And what is the most common example of male pseudohermaphrodite? Androgen insensitivity. And what is the most common cause of ambiguous genitalia in double X? What is the most common cause of ambiguous genitalia in double X? Congenital adrenal hyperplasia. Very good. Now we will study primary amenorrhea. Okay. What is primary amenorrhea? Primary amenorrhea means that karyotype is equals to genotype. There was slip of tongue in between. Okay. What is primary amenorrhea? What is primary amenorrhea? Primary amenorrhea is absence of absence of menses, absence of menarche. Primary amenorrhea is absence of menarche. Primary amenorrhea is absence of menarche. Okay. So, if the secondary sexual characteristics are present, then what is the age? And if the secondary sexual characteristics are present, then what is the age? This is very important question. If secondary sexual characteristics are present, then the age is 15 years. It means if the breast is present, then there are chances that very good. If the breast is present, then there are chances that periods will come. Okay. So we have to wait long. And if the secondary sexual characteristics are absent, it means that the chances are not there that the period will come. Then we have to wait only up till 13 years. Okay. Will you remember it? Okay. Now the breast staging is done by which system? The breast growth is estimated by which system? Tanner staging. Okay. And here only I would like to tell you the hirsutism is yes. But the hirsutism is, you are very right, Dr. Isra. Hirsutism, the hair growth in a female is estimated by Feynman-Galvin scoring system. Okay. You have to learn these both the names. Now let us see how we will assess the primary amenorrhea patient. Okay. When it comes into the OPD, you have to see whether the breast is present or not. Okay. Whether the breast is present or not. If the breast is present and uterus is present, then you have two differential diagnoses. Okay. Now the first category is breast and uterus both are present. Then your two differential diagnoses are imperforate hymen and transvaginal septum. Okay. Imperforate hymen is much more common than the transvaginal septum. So, if you are not, if in the option, both the options are given imperforate hymen and transvaginal septum, and you are not able to differentiate, then you will mark imperforate hymen. It has come once in the MCQ. Okay, breast is present, uterus is present, the girl is not having periods. What is the diagnosis? And the options were imperforate hymen and transvaginal septum. So the answer was imperforate hymen, because imperforate hymen is much more common than the transvaginal septum. Okay. Okay. Next is cyclic. Next is, what is the history given by the patient? The history which is given by the patient is cyclical, or you can say monthly abdominal pain. Okay, the patient is having imperforate hymen or transvaginal septum. In both the cases, the patient, what is the history? You are asked quite frequent about the histories. Okay, so the patient will have cyclical or monthly abdominal pain around puberty, and this pain will start at puberty. Okay, there is also hematocolpos. Okay, and what is your finding on the bulging what is your PR finding? What is your per rectal finding? Can anybody tell me? On per rectum, there will be bulging mass in the vagina. Okay, on per rectal, there will be bulging mass in the vagina due to hematocolpos. And hematocolpos means blood in the vagina. Colpos means vagina, hemato means blood. Hematometra means blood in the uterus. Once in the FMG, they have asked if in the patient of imperforate hymen there is blood in the vagina, what is it? The diagnosis is hematocolpos. If the blood is in the vagina, then the diagnosis is hematometra. Okay, what is the treatment of imperforate hymen? The treatment of imperforate hymen is cruciate incision, cross incision. Okay, in the first category we studied that there is breast and uterus both were present. Then the diagnosis was differential diagnosis was imperforate hymen or transvaginal septum. If breast is present and uterus is absent, then what is the differential diagnosis? Either it is MRKH or it is, come on everybody, either it is MRKH or it is androgen insensitivity syndrome. Okay, so in the MRKH, why there is present breast? Because everything is normal in MRKH, only the uterus is absent. Okay, and why there is breast in androgen insensitivity syndrome? Because the male androgens, which are much large in amount, they get changed into the estrogen. Okay, what is the PV finding in the both of these conditions? There will be blind vagina. Okay, blind vagina, and on PR the uterus will be present. On per rectum the uterus will be present. What is the first step? This is very frequently asked in FMG. What is the first step? A patient comes to you with breast was present, the rectus was absent, uterus was absent. You did PV and you find that there is blind vagina. Okay, beta, karyotype is usually the last step. Okay, what is the first step? Questions are asked quite frequently in first step and last step. Okay, so the first step is ultrasound. First we will confirm our finding by ultrasound, that whether the ultrasound is also says uterus is absent or not. Okay, first we will do the ultrasound. Why we are doing the ultrasound? To confirm that whether the uterus is absent or not, to confirm our findings. Okay, and what else the ultrasound will tell? Dr. Sabri, Dr. Isra, can you tell me what else the ultrasound will tell? What are the gonads? Okay, what are the gonads? whether the gonads are ovaries or testes. Okay, so now let us see the differential features of Mullerian androgen insensitivity and Mullerian and androgen insensitivity, MRKH and AIS. Okay, pubic hairs are present in MRKH, they are absent in androgen insensitivity syndrome. In the Mullerian agenesis, the ovaries are present, whereas in the androgen insensitivity, ovaries, instead of ovaries, testes are present. Okay, is it okay? The testosterone is normal. The testosterone is normal, whereas in the AIS, testosterone is much excess. The karyotype is XX in the Mullerian agenesis, whereas the karyotype is XY. Okay, so as you know that the testosterones are much excess, so after getting the ultrasound done, what will be our next step? Our next step is to get the testosterone done, and the last step is karyotyping. Okay, the last step is karyotyping. Is it okay? Okay. Okay. Now you tell me, this androgen insensitivity is the most common cause of male pseudo hermaphrodite. Okay. What is the another name of androgen insensitivity syndrome? What is the another name of the androgen insensitivity syndrome? The another name is testicular feminizing syndrome. Okay, another name is testicular feminizing syndrome. Is it okay? Now, the testes are present in these patients. So, the testes removal is done at, the testes are to be removed at, please tell me, when are the testes to be removed? The testes are to be removed at puberty. The testes are to be removed at puberty. Okay, the vagina is constructed. These patients, they have blind vagina. Both Mullerian agenesis and AIS, they have blind vagina, so that they can live their normal life, they can have intercourse. The vagina construction is done just before or after marriage, so that while they are doing intercourse, if they will use it, then their vagina reconstruction will be fruitful. Okay, is it okay? So the vaginal construction is done just before and after marriage. Why we do gonadectomy in the AIS? Because these gonads, these testes, they can become yes, they can become cancerous. Okay, and why we are not doing at childhood? We are not doing at childhood because if we will do it at childhood, then the patient of AIS will not have breast. Right? Okay, so this patient will not be reared as female. Okay, if the patient does not have breast, so the patient cannot also live as female. That is why this is only the single permission which is given by the Supreme Court to do the gonadectomy at puberty after the formation of breast. Okay, now the last case. Now the last case of primary amenorrhea, that breast is absent and uterus is present. Okay, breast is absent and uterus is present. Then what we can do? If the breast is absent, beta, then the estrogen is absent. It means that the estrogen, either it is ovarian failure or it is hypothalamic failure. Okay, either it is ovarian failure or it is hypothalamic pituitary failure. Okay, are you there, Dr. Isra? Are you there, Dr. Isra? Okay, so if there is hypothalamic pituitary failure, then FSH decreases. Okay, and it becomes the case of anosmia or Kalman. Okay, okay, so if there is estrogen is absent, and if the breast is absent, it means that estrogen is absent, right? So either it becomes the case of hypothalamic pituitary disorder or the ovarian failure. If it is hypothalamic with pituitary failure, then FSH will decrease. Okay, and if it is ovarian dysgenesis, then the FSH will increase. What is the reasons for hypothalamic failure? What are those syndrome known as Kalman syndrome? Kalman syndrome. Okay, it is Kalman syndrome. And what is the typical history given by the patient? The typical history given by the patient is anosmia. Typical history given by the patient is anosmia. Okay, and if there is ovarian dysgenesis, then it is the Turner syndrome. And what is the history given by the patient? That the first of all, the mental status of the patient is very fine. Okay, the mentally the IQ is very normal. What are the heart diseases the patient has? They have coarctation of aorta. Okay, then they have neck edema. Then they have microgenetia. This jawline is very short. This jawline is very short. Okay, they have diabetes and hypertension. Their chest is shield-like and they have short height. So these are very typical characteristics they are going to ask you. First of all, their height is very short because one X gene is absent. And they have shield chest, that is no breast. Okay, and then they have neck edema, microgenetia, diabetes mellitus and hypertension. Is it okay? Okay, so if a patient of primary amenorrhea comes to you, you have to see whether the breast is present and uterus is present or not. Okay, next you have to see that whether the breast is present or uterus is absent. Okay, next you have to see whether the breast is absent or uterus is present. Okay, so this way you have to categorize. If the breast is present and uterus is present, then what it is? It is androgen it is imperforate hymen or transvaginal septum. If the breast is present and uterus is absent, it is either MRKH or androgen insensitivity syndrome. Okay, if breast is absent and uterus is present, then it is Coleman or Turner. So this way you have to categorize. Okay, now let us study secondary amenorrhea and finish this topic. Okay, what is secondary amenorrhea? It is not so like that. It is not like that, Dr. Isra. Okay, let's start it. Secondary amenorrhea. What is secondary amenorrhea? First step in the secondary amenorrhea is we have to rule out pregnancy. We have to rule out pregnancy. Okay, first step is we have to rule out pregnancy. If beta HCG is negative, then we have to get the 3 tests done: FSH, TSH and prolactin. So the most common cause of secondary amenorrhea is pregnancy. Okay, first we have to rule out pregnancy, and if the pregnancy is negative, we have to get done beta FSH, TSH and prolactin. Okay, how does the prolactin cause amenorrhea? Question can be asked to you. How hyperprolactin cause amenorrhea? Yes, it cause amenorrhea by suppressing gonadotropin releasing hormone. By suppressing gonadotropin releasing hormones. Okay, by suppressing gonadotropin releasing hormone. Yes, so now let's start it. Let's start it. If the FSH is increased, then what it is? If the FSH is increased, what it is? If the FSH is increased, then what it is? Can you tell me? If the FSH is increased in secondary amenorrhea, then it is premature ovarian failure, because ovaries have failed and now the estrogen is not giving the negative feedback. Okay, estrogen is not giving the negative feedback. If the FSH is normal, then it is a case of PCOS. Okay, then it is a case of PCOS or Asherman syndrome. If the, are you getting it? If the FSH is high, it is a case of premature ovarian failure. If the FSH is normal, then it is a case of PCOS or Asherman syndrome. Is it okay? Now this PCOS patient, what is the history this PCOS patient give? It gives the history of hirsutism. And what is the history the Asherman patient give? They give the history of curettage or TB. Okay, they give the history of curettage or TB, right? And if the FSH is decreased, then it is Sheehan syndrome. Okay, and here the patient also gives the history of lactation absent and PPH present. Is it okay? There also it gives the history of lactation absent and PPH present. Is it okay? Clear? So simple. In the case of secondary amenorrhea, we have to get the FSH done. If FSH is high, it means it is a case of ovarian failure. Beta, in PCOS, we are coming to that. Okay. In PCOS, we have to do progesterone withdrawal test. Okay. So now it is very simple. In the patient of secondary amenorrhea, if pregnancy test is negative, you have to get the FSH done. If FSH is high, it is a case of premature ovarian failure. And if the FSH is normal, it is either PCOS or Asherman. And in the case of PCOS, it will give you the history of hirsutism. And in the case of Asherman, the patient will give you history of curettage or TB. And if FSH is decreased, then it is Sheehan syndrome. Patient will give you the history of absence of lactation and history of PPH. Now let us discuss in small about the estrogen progesterone challenge test. So estrogen progesterone challenge test means we are giving the patient estrogen and progesterone, and then the patient bleeding is occurring. So the fault can be at the level of estrogen progesterone challenge test will be positive if there is deficiency of estrogen and progesterone. Deficiency of estrogen and progesterone. If there is deficiency of estrogen and progesterone, and deficiency of estrogen and progesterone is in hypothalamus failure. Yes beta, we measure FSH before withdrawal test. Okay, hypothalamus failure, pituitary failure and ovarian failure. In all these three cases, there is deficiency of estrogen and progesterone. Okay. But there will be no bleeding if there is any uterus or endometrial problem. Okay. If there is any uterus or endometrial problem. Okay. So in these cases, there will be bleeding if there is deficiency of estrogen and progesterone. In the progesterone challenge test, there will be bleeding is there. It will be positive in the case of PCOS, because in PCOS there is an ovulation and there is deficiency of progesterone. There is deficiency of progesterone. So in the case of PCOS, there will be bleeding on, yes. Is it okay? Should we do questions? Please answer this. Not classified as primary amenorrhea. Now these are 20 expected questions. Not classified as primary amenorrhea. Please tell me. The answer is Sheehan syndrome. D. Very good. Question number second. 15-year girls absent breast present uterus karyotype is 46XX. Come on fast. 16-year girls absent breast uterus present. 16-year. Yes, it is A. No, it is not A, Dr. Isra. In this, the genotype is XO and here the genotype is XX. So, answer is D. Okay, answer is D. Right? What is the answer of this? Most common cause of female pseudohermaphrodite. So the answer is androgen insensitivity syndrome and in the male it is AS. Very good. What is the answer to this? Here there is secondary amenorrhea. History of DNC is present and FSH is 7. That is normal. What is the diagnosis? The patient is coming with secondary amenorrhea. Yes, the answer is Asherman. I told you that in a patient of secondary amenorrhea, if the pregnancy test is negative, we will get the FSH done. If FSH is high, it is no beta, no. Dr. Sabri, it is D. Okay? If FSH is high, then it is the case of If FSH is high, then it is the case of ovarian failure. Since FSH is normal, it is a case of, and if FSH is normal, it is either PCOS or it is the case of Asherman or uterine syncope. And if FSH is decreased, then it is the case of Sheehan. Okay, since here FSH is normal, so it is the case of Asherman. In PCOS, patient gives the history of hirsutism. Take this next question. Take this next question. Normal levels are 4 to 7. Yes, it is 4 to 7. So here it is no treatment. Why it is no treatment? Can anybody tell me? Because if the breast is present, then what is the age? Yes, because if the breast is present, we have to wait for 15 years. Okay? Most common cause of secondary amenorrhea is pregnancy plus lactational amenorrhea. So you have always to consider the lactational amenorrhea along with the pregnancy. Okay. So the answer to this question is no treatment. Okay. A infant was having ambiguous genitalia, dehydration and tachycardia. Okay. Infant was having ambiguous genitalia. So it means that it is either a case of AIS or testicular. Right? Is it okay? So now further they have seen that there is hyponatremia and hypokalemia also present. What is the enzyme deficient and what will be raised in the blood serum? First tell me the diagnosis. It is deficiency of 21 alpha hydroxylase. Okay, it is deficiency of 21 alpha hydroxylase and 17 hydroxyprogesterone is increased. Okay, the path it gets increased. Is it okay? Will you remember it? Now, this is a case of primary amenorrhea. They haven't tell you about breast or uterus. कुछ नहीं बताया. They have just told you about urinary retention. What it will be? Yes, it is a case of hematocolpos. It means urine retention is means something is pressing the. So what are the six differential diagnoses you have? What are the six differential diagnoses for the primary amenorrhea? Either it is imperforate hymen, or it is transvaginal septum, right? The second is AIS and MRKH. Next is Turner and Kalman. In all of these, only imperforate hymen and TVS can only cause urine retention. Okay? So that is the advantage of systematic study. Even if they don't tell you anything, you can find out. So short height and shield-like chest is present in Turner. They have further supported, very good. They have further supported you by saying that FSH is high, right? So FSH is high in ovarian failure. So the answer is ultrasound small uterus and gonad. Take the next question. They are telling that breast is present and hairs are present. It is answer is next step. Next step will always be ultrasound. And what next you will do, beta? What next you will do? Testosterone. What next? Karyotyping.